put you kind of in the picture, and a disclaimer, as you all know, I'm not a glaucoma specialist, but I think that, we will see these sorts of cases, and even a general ophthalmologist, you guys will see them as well. So it's good for us to know something about them. Hello, welcome. Help yourself to a drink and some food. They're forms of secondary glaucomas. We're just talking about Posner Schlossman Syndrome, and I'll take it back, and Fuchs Uveitis Syndrome. So they're secondary glaucomas, and they're on the whole list of secondary glaucomas. They're the glaucomas due to uveitis. So, and there's a whole list there for completion. But Posner Schlossman Syndrome, after the two fellows that discovered and reported the 9 cases in 1948, is also known as Comatocletic Crisis. And it is a rare condition. And these were the 8 features that Posner and Schlossman reported. So they tend to be unilateral, recurrent conditions, and patients don't have much by way of symptoms. A little bit of discomfort or maybe some blurring of vision. And that's the reason why they might turn up to you. Their pressure can be elevated with open angles, and quite considerably elevated, 40 to 50 milligrams. It's even been reported as high as 70 millimeters of mercury. Sorry. The anterior chamber reaction is, it's only mild. You might see some fine white KP, and these crises of elevated pressure can last from several hours to weeks. And in between, the challenge of making the diagnosis is that their pressures can be normal and there's no signs of uveitis between attacks. And then in the early phase, they'll have normal visual fields and optic discs. So, and the key thing about the pressure, which is quite amazing, is that the degree of pain is not in keeping with the degree of elevated pressure. So, for somebody to develop the pressure of 40, you'd kind of expect that have at least an ache. By the time they're getting to 50, 60, 70, you think that they should be throwing up and looking rather green and being in a lot of pain, but it's quite surprising that they're not. And their degree of inflammation is also quite mild. And the reason why they require ongoing monitoring is that they can have glaucomatous damage because of those repeated attacks of elevated pressure. So what can Posner Schlossman Syndrome look like? Well, it can look like Fuchs Uveitis Syndrome, previously known as heterochromic iridocyclitis. It can look like herpetic keratouveitis, and it can also just look like uveitic glaucoma, where you have inflammation and your pressure goes up. And then, of course, the usual acute angle closure or chronic angle closure or even primary open angle glaucoma. In terms of what's the underlying reason, well, we don't really know. There's lots of theories. They talk about perhaps some genetic association. CMV virus has been thought to be associated. HSV, zoster, and even Helicobacter pylori, which is the bug that's associated with stomach ulcers. And why is the pressure elevated? Well, it's not the typical culprits where you have inflammation and you get trabeculitis. And it's not because you have inflammatory debris obstructing your trabecular meshwork like you do have when you have quite a lot of inflammation. Because remember that the inflammation is really mild. And so the cause is really a big question mark. And there's theories about have there been alterations in the vascular regulation, or is it autonomic changes? Treatment, fortunately, they do respond quite well to the usual topical oral Diamox and also steroid treatment. What's not clear, and I think it's because the condition is so rare, it's really hard to do a long-term study to look at the outcomes, is it useful to treat them and have them on something long-term, and will that be enough to prevent those pressure spikes and those attacks? So we don't know that because in between the pressure is normal, and that is one of the ways that you can distinguish between Posner Schlossman and other forms of inflammatory glaucoma. And like I said, these patients, they do need monitoring. the challenge is that even if you see them annually, they might have an attack in between times. So it is quite tricky. And, there was a retrospective case series that looked at patients with PSS, and they noted that the longer you had the disease, the more likely you were to show all those typical glaucomatous visual field defects and optic neuropathy changes. So I'm going to present a case, and this is patient X. She's a 50-year-old female, and she just presented to one of you for a routine review and a check to see if she needed glasses. She had some history of uveitis that was treated in Dunedin, and she's kind of mentioned some vague history of maybe the left pressure was high, and she wasn't on any treatment. Visions were reasonable, maybe a little down on the left, but certainly the disc on the left side was had a CTD of 0.8, and it was pale, had a thin superior neuroretinal rim, and the pressures were reasonable. She had perhaps a few fine KP on the left side, but no active inflammation, and her angles were open. And that was her left visual field. The right side was normal, so I didn't put it up. And so here's another case. 52-year-old lady. She presented to one of you with blurred vision in her left eye, and she'd been treated with glaucoma in the past with eye drops, and 3 years ago was told to stop. Vision's reasonable, pressures are reasonable, anterior chambers are quiet, there's no RAPD. 2 mutton fat KP on her inferior cornea were noted, and her discs, the right side looks reasonable, but the left side quite deep cupping. And that's her visual field, so hopefully you can tell that the left side has significant and diffuse loss, and a few patchy changes on the right, which may or may not be real. Here's another patient. She's had several episodes of uveitis. In the notes it did say, is this Posner Schlossman Syndrome? It's a bit of a tongue twister. She's had no systemic symptoms and hadn't been seen in 3 years, but she hasn't really had any pain in her eye, which you would expect if you saw somebody with acute uveitis. She'd had episodes of blurred vision, but she was quite vague about the symptom, and some floaters, and then she'd had these left-sided parietal headaches, and the cause was unclear. But her visions were reasonable, pressures were reasonable. She doesn't have particularly thin or thick central corneal thickness. She did have a left RAPD, and it was corresponding with that significant cupping on the left side, and her angle was open, and there was no documentation as to mention of KP. And it is a point that even I have to remind myself that you actually have to look for KP. It's quite easy to miss them if you don't specifically look for them. And on OCT, there was RNFL thinning noted on the left side. Humphrey visual field hadn't been done at this point in time, but the conclusion was that she's got low pressure. It's an atypical unilateral glaucoma, but certainly they were thinking twice about the diagnosis. And so actually, all those 3 patients is the same patient, just at different scenarios. And, you can see that vision was reasonable, pressures were normal. Yes, there's a history of uveitis and signs of old KP and progressive deterioration in her cup, but you don't know that because you only see one snapshot of that in a normal visual field. So I'm going to go back to the beginning and start where I have been able to track her journey from. So this started back when she was 47. She presented to her GP in Oamaru, and her GP then referred her on to an optometrist because it was on the weekend. She'd presented with headaches, blurry vision for about 3 days in the left eye. You can see the vision on the left side was down. Pressure of 50. Maybe the headaches was the reason for the pain, but she certainly wasn't complaining of eye pain. Pupil was sluggish, mid-dilated, and the cornea was edematous, and because of that, couldn't get a good view of the anterior chamber or the fundus. And what was noted was perhaps there was some central mutton fat KP. And I'll come back to KP later in the talk. But anyway, together with consulting the registrar on call and getting the GP to prescribe some of that medication, she was commenced on treatment to lower the pressure. And the optometrist, I think, went above and beyond because that was a Sunday. I don't think too many of you work on a Sunday, hopefully. And the pressure had come down to a reasonable level of 29 in the cornea. interesting how quickly it changes, because you know that from an angle closure attack, it doesn't come down that quickly. But anyway, so it came down, and cornea was clear, and they were now able to see that there's only trace cells in the anterior chamber, and certainly noticed a big difference between the two sides, and the fields were described as normal, and that's so a couple of non-specific patches, but certainly on the left side, other than the few patches there, it's not bad, and I think the right side was probably more artifactual. So not long after, I think that Monday, she was seen at the Dunedin Eye Clinic, saw the registrar, told the registrar that she'd been having some mild headaches and some blurry vision for several weeks, no history of trauma, and really not much to find. There's not much reaction in the AC, pressures are normal, discs, there's a bit disc asymmetry, and even at that point in time, because I think of all those features, they thought, well, is this uveitis with secondary glaucoma? But they were already talking about Posner Schlossman at the time, and treated with some Pred Fort as well because of the little bit of inflammation. So a couple of weeks later, came back to the eye clinic in Dunedin for a follow-up. Because the pressures were, and in between, she was advised to stop her Diamox, which I think is quite reasonable, because we want to see sometimes after the pressures come down, what is the pressure off the Diamox. But then the headaches recurred, so she went back onto it, which I think is also a reasonable thing to do. But interestingly, the headaches persisted, and then it was thought, well, maybe it's not because of the eye. And in between, she did also see her optometrist in Oamaru, and the pressure was reasonable at 14. So at this visit, pressure was 10 on the left side, and the eye was nice and quiet, no abnormalities on the fundus. And there was just a comment about, well, what does that 0.7 disc mean? Is it physiologic? And I think, even that one snapshot in time, you don't really know. So they decided to stop the Diamox and Alphagan. And you can see on the left side, especially where it says the 86, I don't know if my mouse is, no, sorry, where it says 86, where you've got actually I think I might have got some animations in there. So yes, you can see the large cup, and what's not projecting up very well, but it didn't come up very well on the OCT, was that the RNFL plot of the left side was below the right side. And you can certainly see that the superior RNFL quadrant is on the thin side. And this is just a blown up image of, might try and dim the lights there, John, for a moment, please. Oh, thanks, Justin. So the right side's about 0.4, and the left side, you might be able to see that the cup size is a bit bigger, but the neuroretinal rim still looks not too bad at this point in time. Okay. So she was followed up another 2 weeks later, and she'd had a little bit of redness on the left eye, but settled with some polytears. And she'd self-tapered the Pred Fort. Visions were still good, pressures were still fine, eyes were still quiet, but those granulomatous KP were noted, and her discs looked stable. And they did explore her headaches fully, and worked out that it was the temple and top of the head, came and went, lasted about 30 minutes. Particularly in the evenings, but they're gone by the morning, and they weren't really sure what was the cause. So referred her to a GP, and then said, come back whenever you have any issues. So no routine follow-up was arranged. And then the GP had arranged a CT head, and nothing worrying was found. So I think that was reasonably diligent. So fast forward a year, and she turned up again to her Oamaru optometrist, and said that she wondered if she'd had more episodes over the 3 weeks preceding. But really, as you can see, nothing much to find other than the old changes. But her disc, 0.8, so is that worse? Is that just inter-observer variability? But anyway, did the right things, a visual field test. I'm sorry, that's the only copy of that I have in the notes. But it's also one of the reasons why you might find that the eye clinic goes, I'm sorry, your fax hasn't come up with any information that we can interpret. So thank you to all of those of you who have been troubled to send us a colour copy. And that's her visual fields. So I'm just going to pause here for a moment and just talk about some broad principles. this is the way the facts came out. Can anybody comment on the layout of those fields? I'd like to. And the point here that I want to make is really just something that's quite fundamental, doesn't always apply to glaucoma, and will help to reduce the confusion in terms of when you're describing the fields as whether there's a nasal defect or a temporal defect. Jeremy, I can see you're itching to say something. They're the wrong way around, yeah. So, I mean, it is a 101 kind of concept, but it's very easy to get muddled. So if you laid this out, you might incorrectly say there's a right temporal visual field defect. But in fact, that's the left eye, and that should be on the other side. And then you can, accurately describe and not get yourself into a twist, and you'll accurately describe that as a left nasal defect. So it is, and I do make that point, and we stress that point with the registrars as well, because from time to time we get a referral that talks about the field defect, and clearly the fields have been laid out the wrong way, and people have described them as binasal instead of bitemporal, or vice versa. Okay, so life gets in the way of your follow-up appointments, and I think she moved cities in the meantime, so she didn't land up getting seen for those 2 appointments. And then she turned up here in Christchurch, and she just went for a routine review, gave the history that I've had inflammation in my eye, was treated Dunedin, vague history, and that was the slide that I showed you earlier. But what was noted by one of you was that she had a pale cupped out disc, though the pressures were normal and the KP were detected. And that was the visual field that I showed you earlier. And this is the right side now, so you can see the right side is pretty good. Hard to know what that spot is, but anyway, it needs monitoring. So she didn't make her appointment in December, and it was rescheduled to February, and she got seen eventually in the uveitis clinic in March. And so you can see how the months just tick by. And anyway, so the KP were noted, and they were described as larger old KP. The disc now described as 0.9 on the left, and no underlying systemic causes identified. And because the eye was quiet, she was then referred on to the glaucoma clinic. And the glaucoma specialist thought that this is a bit puzzling, noting the several episodes of uveitis and the history of possible Posner Schlossman Syndrome. And the reason why there's always a question mark after that is because we don't have a test, or we don't have, especially in the early phases, you kind of wonder about the diagnosis, but you don't really know for certain. The time that you know for certain is usually in retrospect with the value of hindsight. Anyway, it was noted that she'd been living in New Zealand for a while, no systemic history, hadn't been seen for about 3 years, but in that time, other than having episodes of blurred vision which were intermittent and a few floaters, she'd had no pain, and still had those left-sided headaches, which the cause is unclear. And those parameters you've seen, because I showed that to you earlier. But she certainly had a left RAPD and corresponding with the marked cupping. And still a quiet eye. Didn't mention the KP, but it's just one of those things. Sometimes in your notes, and I always say to the registrars, negative findings are important as well. So it would be worth mentioning. So at this point in time, you have this snapshot, and I'm not even sure that the glaucoma specialist had the history that I've just shown you, because it's a different system. So potentially all he had was this information, and so it was quite reasonable for him to go, well, you've got this marked cupping and this history of uveitis, and it's quite significant. We should look for a reason, and that would include a number of blood tests to look for an underlying reason for the uveitis, and an MRI scan to look for to rule out an intracranial cause. So one of the referrals before this had noted that there was no RAPD, and I think it's at this point I just digress slightly, and I'll move on to RAPDs, because they're such a critical part of an assessment, And I mean, so much so that I personally prefer to see the RAPD myself. So even in clinic here or at public, I'll make a note that when the patient comes back, I want to check the RAPD myself. And when I learn to trust my registrar, that they know how to check for an RAPD, then I'll rely on them. And it is difficult. It is a really tricky thing to pick up because they're not always that straightforward. And so here's a video clip, which Justin's going to hit the lights. So we might show it once, and then if you want to see it again. And you'll notice particularly this poor lady, you can see the scar on her forehead. She'll end up having a traumatic optic neuropathy. But even the first time you shine the light on the right pupil, it doesn't really constrict that convincingly. And you'll also have to forgive me as the videographer trying to handle the video camera and the ophthalmoscope at the same time. So forgive me. And it wasn't too bad. So it's quite a nice constriction. Not much there. And there wasn't much of a constriction and not much of a constriction. So you can see how variable it can be. But anyway, when I finally did actually manage to get myself coordinated and lined up, you can see the constriction on the right and the dilation on the left.
If that's 100% of brightness.
Mm-hmm. Don't worry about the audio.
Before I thought it was probably about half, but it's probably less than that.
We're just simultaneously trying to test subjective light brightness, which can be, I mean, particularly if you have a patient who's got some confusing history and you're trying to ascertain whether there is something pathological going on. It's quite nice when your ducts will line up. In other words, there's red desaturation as well as the RAPD as well as subjective light brightness that's reduced on the one side. When you have these patients that come in and you're not really sure if there is something real going on, and they go in the eye that's supposed to have the problem, oh, that's way brighter than the other side. Well, that doesn't quite fit with an optic neuropathy. Okay. Does anybody want to see that again? No? Happy? Okay. So that was her visual field, and you can see her blind spot on the right side's not mapped out that well, and the left side there's diffuse loss, and this is by 2017 now. So she had an MRI, and well, the trouble is that you find things that I'm in hindsight, I'm not convinced about this, but that was the report. The report came out that said that there's increased signal on the optic nerve, and there's some non-specific white matter spots. And what does it mean? Well, all the radiologists can do is give you a differential, and then you have to apply that to the clinical picture. So those spots could be just normal for her age, or does it suggest demyelination? And, when you see somebody you've only got this one snapshot where they've got a pale disc and an RAPD and they're fully recovered, it's not crazy to actually conclude that maybe she had optic neuritis, and now you've got radiological evidence that she's got optic neuritis. So you can see how you can really get sent on a bit of a goose chase when you're trying to make this diagnosis. Anyway, so based on that, she was appropriately discharged, because once optic neuritis has occurred and recovered or not, we can't really intervene that far down the track. So she was discharged. So a couple of years later, she turns up to one of you again, and she complains that her vision is blurred on the left side. And she gives that history, and this is the slide that I showed you earlier. Pressures are not terrible, but you certainly see the cupping and the old KP. And those are the visual fields, so quite diffuse loss. And then she got referred to the eye clinic, seen by somebody else. And this history of blurred vision, no eye pain. They reviewed her history, still no systemic symptoms. And then they ran a whole battery of tests. And then what was quite odd, apologies for the spelling error, is that her quantiferin gold came back as low positive, and it's a test for TB. And it's one of those things that we look at it and we go, well, how are we supposed to interpret this? So we refer them on to the infectious diseases team, who also look at it and go, well, we don't really know what we're supposed to do with this, because she's got no symptoms, but then she could have latent TB, so we might treat her. And then the person that saw her thought, well, maybe this is TB uveitis. But I don't think that's true. I haven't seen a truckload of TB uveitis because we just don't see it in New Zealand. But she just had a pristine fundus other than the disc on the left side, and I just don't think it fitted. And even the infectious disease consultant kind of wrote back to us afterwards saying, I don't really think that she's got TB uveitis, but it is a possibility. And, not surprisingly, her vision was still very good because she's got that little tunnel of vision where she still has very good acuity. But her pressure was up at 40 on that visit. She had a few white KPs, and white KPs perhaps suggest that they're active rather than old. And she's still cupped out. So they treated her with Predfort and some drops to lower her pressure. And because it was reasonably high, they checked her 3 days later, and the pressure had come down very quickly, and the eye seemed to be have responded quite well to the Predfort, and that was her visual field. So, she's still hanging in there with that little tunnel, but the right side seems to be good. So, what I just did was I kind of summarized and just focused on the pressure. So, and this is really just to show you the journey. So, August, pressure's 40 on the left, treated with drops, came down to normal. They stopped at the bromonidine, kept her on the high side on the azopt, checked her a week or two later. It was still reasonable, so then they could stop one more agent. And then by the time we came down to nearly 2 months down the track, her pressure's still under control. We stopped the azopt and keep monitoring. So, and then by December, pressure's still reasonable, so let's stop all treatment, which is reasonable. Let's see. And then she turns up to clinic in March, and she says, I have the occasional prick in my eye, but my eye never gets red. I don't have any ache. And I think my vision's getting worse. And she's probably right, 612. But I think the reason why she was worse is because her pressure was 62. Isn't it astounding that she was asymptomatic? But I think that's part of the clinical picture. That she's only got a little bit of mild conjunctival hyperemia, and she's got microcystic edema, not surprisingly. And she's got those old KP on her endothelium, not a lot of inflammation, and the view of the fundus was hazy. So that was the first time I met her, and treated her with some oral treatment and drops, and got her to come back in the next day just to see how she responded. And she responded amazingly well, because pressure came down to, I didn't write it down. Anyway, it did respond. And then she was recommended to stop the Diamox, and as usual, we just try to taper things down. 2 weeks later, pressure's 21 on the left, and then we went into lockdown. But then I figured that it was still important to see her because I had no idea what her pressure was doing. And so you can see that her symptoms are just, I've got a little bit of blurred vision in my left eye, and sometimes it's only there for a couple of seconds, and sometimes it can be there for half a day. And her eye was still nice and quiet. But her vision was still down, and I think that that optic neuropathy was finally starting to catch up. She's still hanging in there with a little tunnel on her left visual field. And this was her OCT RNFL, and I'm quite surprised that it actually looks that good. I certainly would have expected more diffuse thinning. Maybe that's to come. So I thought I'd just talk a little bit about Posner Schlossman Syndrome, and just these are the take-home messages, really, because it's going to be quite difficult for you to make that diagnosis when you only have one snapshot of that patient in time. But the key things is those things that Posner and Schlossman described. It's typically unilateral, recurrent. The symptoms are relatively mild for the degree of raised pressure. They don't have a lot of inflammation, and they will have their crises which might last from hours to weeks. And I wonder if those headaches that she'd been experiencing were just when her pressure was elevated for those hours, and then whenever she had a check, the pressure was down to normal, and people were going, well, we don't really know what's causing the headaches, but maybe we checked it when she was at her worst. Those normal visual fields and discs, well, the longer you have this condition, the more you're going to get glaucoma disc damage. I have another fellow who he's made the link between his eye pain, and he says, I just go to my chiropractor and he does something to my neck and he sorts it out. And I just think it's one of those timing things where the pressure probably would come down on its own anyway, but he's made the link that his chiropractor's a genius, so he keeps going back to his chiropractor. I was able to convince him once that perhaps it's not related to his neck when he did turn up one day and didn't have a lot of pain and his pressure was high. But it's, that's a chance check because it was just one of those routine things. Okay, so we're going to move on to Fuchs Uveitis Syndrome. So at this point in time, does anybody have any questions? Maybe you'd like to refill your glass or get some more food before we...
At what age would you start seeing the attacks?
They tend to be younger. Yeah, they tend to be kind of the 40 to 60 age group. Yeah. So, and I think that's one of those things that's worthwhile bearing in mind, because glaucoma tends to be, as a broad generalization, a condition, especially the primary open angle, something that affects older patients. Yep. So, if you see something fishy going on in a younger patient with elevated pressure, it's one of those things that's quite worthwhile doing to check their KP, look for iris transillumination, even step back and look at the color of their irises, because, well, you'll see why in a moment. And also even just alert your patients. I didn't really get the impression that she understood things well, even though, and some people, they don't. You try to explain it, and it takes a while. I think it was 3 or 4 visits later where I was finally able to convey some of the concepts that I was trying to get across to her. Yeah.
Certainly looking at the number of times that she didn't show up, it's like, you've got to wonder, do you get this and the effect that it's going to have on you? And we really need to get you back, and it's like, there'd be months and she just wouldn't show it.
And she's struggled with a bunch of other things, So life happens and people have to deal with things, and she's had to deal with a bunch of other things, and then sometimes the eye just becomes a secondary thing until it's too late and you can't do anything to reverse the damage. Yeah.
Does it ever move into the other eye?
No, this tends to be unilateral, fortunately. Yeah. I think certainly Posner and Schlossman, they described one of their I don't know, maybe diagnostic criteria is a strong word, but they certainly said they notice it as a unilateral condition. And all the ones that I've seen, and it doesn't happen that often, so, but certainly the ones that I've seen that fit the criteria is unilateral.
So has there been any research that suggests whether it's worthwhile getting them to be on glaucoma medication permanently to treat those attacks?
I haven't seen any studies, and I think the trouble is because it's a rare condition, it's difficult to accumulate enough patients that will then, the study has enough power to say, well, you need to, treat them. So, and the trouble is because the pressure comes right back down to normal in between episodes. So this lady, having met her now, and she's hanging on this tiny little tunnel, I have got her onto high sight, and I have said to her, look, I'm not really sure if this is going to prevent an attack, but I think it's worth trying. Yeah. And I think, if you rewound the clock, and if I saw another patient that I suspected had Posner Schlossman, I mean, the value of hindsight is, it's so easy to say looking back, but because, you might be suspecting this condition in a 40-year-old, and the drops, they're not innocuous. We've all seen those patients that have been on prostaglandin analogs for a long time, and their eyes they just look grumpy. The eyes are a little bit hyperemic. They just look a little bit irritable, and they have a foreign body sensation, and it's not that great. And they've got a whole lifetime ahead of them. So it's not as straightforward as, I'll just take this drop. I think this might, because we don't actually know if it's going to prevent an attack. I'd like to think that it would contain the spike, but I don't think anybody knows for sure.
Do you think SLT might have something to do as a role as far as avoiding medication?
Yeah. Well, the trouble with SLT is that if it works, that it's really only a temporizing measure. You might at best get about 2 years out of it, and if you're a young patient, and I don't know. I think it's a good question, but with a rare condition, there's always going to be more questions than answers.
How often is it worth following up these patients, given that they could have a spike at any random time?
It's a very good question, and I don't know that anybody has the answer, but I would say that probably at least a year, every year. Maybe that just makes us feel better. I don't know if it actually serves any purpose, because the trouble is, in between, she could be having spikes, and then it settles down, and then you... But one thing that I think is useful, and you'll certainly find from the point of view of the eye clinic, because if you thought we were bad before before COVID, well, try us now. And we're really struggling to keep up with the load. So, certainly one thing that's really fantastic about working alongside you all is that you have the skills and you have the equipment and you have the technology to be able to monitor the patients. So that, and then if you detect any changes, that is immensely helpful to the patients, the community, as well as us, because that means that you can do the monitoring, and if there's any concern, you can alert us to it and refer the patients in. Yeah. Okay. All right, shall I move on to Fuchs Uveitis Syndrome? So I did have, as a spelling error, Fuch apostrophe S, but I think that the Austrian ophthalmologist was a Mr. Fuchs. Joshua, my 9-year-old, he did say to me, "Mum, that sounds like a bad word." I said, no, it's just a Mr. Fuchs, or Mr. Fuchs rather. Okay, so I thought I'd do this one the other way around because, so I thought I'd present the case first and then we'll talk about the features. So this lady was 36-year-old when her optometrist first detected some creamy deposits on her left corneal endothelium and a mild cataract. So you'll have to forgive me because I wasn't able to actually get my hands on her file, and everything was on Health Connect South, and the information I gleaned was just from the letter, so there might be bits of information that there are gaps. So I don't really know why she went to her optometrist. Maybe it was just for a routine check, because certainly her vision was great, although, I don't know, maybe she was starting to notice that left cataract. And she had some inflammation in her left eye, but it's not uncommon that people don't notice it. And she had subtle heterochromia, which I thought was pretty amazing that was picked up. And because, again, it's another feature that if you don't look for it, it's so easy to miss. And I'll show you a photograph shortly. The optometrist picked up that she had a mild PSCO, which certainly would give you more symptoms than what the visual acuity might show. And there was a question mark in the notes, is this maybe Fuchs heterochromic iridocyclitis, as it used to be called? So she was seen, reviewed, she was initially treated with Pred Mild, which we don't have anymore, and then reviewed, and the pressure seemed to be fine, and the Pred Mild was stopped and she was discharged, but came back in August because the record shows that she had left iritis that was slow to resolve. Vision unaffected. There was no mention of pressure in the letter, but she was changed to Pred Fort, advised to taper it, told to come back in 6 weeks, and I have no information after that, so there's a bit of a void. The next record I was able to access was 2009, so the notes document that she has Fuchs and that she'd had cataract surgery in February 2009, happy with her vision, pressures were normal, and her eyes were quiet, and she wasn't on any treatment. And then a year later needed YAG laser treatment. Another 5 years later, she started to have some symptoms, a small amount of ache on the left side, and went to her optometrist, who found that her pressure was 45. We found the same, and also noted that she had a left RAPD, that her she had some pigmented KP. The angle was open, which I think is I didn't stress that much when I was talking about Posner Schlossman, but one of your differentials when the pressure is so high and the cornea is steamy is acute angle closure. So that's really a key thing to note, and so her angle was open. Noted the significant disc asymmetry, started her on treatment to lower the pressure, which responded nicely, came down to 10. And then we stopped some of the other things and carried on with bromonidine. And I think she had asthma, which is why she's not on timolol, which is often our first line. It was noted that she had a left supratemporal infratemporal scotoma, and the OCT also shows that her left superior and inferior RNFL quadrants are thin. So all fitting. So So once again, next, I don't know, maybe 5 or 6 slides really just documents her journey from 2006 to today. And you can see how, again, I'm just focusing on the pressure and more just to give you an idea of the journey, because like I said, with the first case, all you see is one snapshot. You don't get a sense of what happens to this patient right throughout. So her pressure responded to the treatment. So coming down to September, pressure snuck up again, so we added high site. Pressure wasn't great in November, so changed to Combigan. And so these are just kind of the normal things, and then until we can actually get the pressure either controlled or the patient starts to be struggling with some side effects. And she was struggling with her mood and her blood pressure. So it's reasonable to think that timolol is the culprit. So the Combigan was stopped, added Travatan, but then in May 2015, the left pressure went up to 33, and she did actually have a bit of an ache. So she was put back onto some oral Diamox to try and control that a bit better. And then just continuing on with the journey. So that's just the last visit. Pressure came down, but she wasn't tolerating the bromonidine that well, and her drops had changed, but pressure went up to 46. And so you can see this whole journey, I think, maybe I counted about 13 appointments over a 10-month period. And you can just see every single eye drop has been tried and all different permutations and combinations. And finally it was just, she wasn't tolerating the oral Diamox. She was getting a lot of side effects. And so she was waitlisted for a trabeculectomy with mitomycin C. So July 2015, she had the surgery, and not uncommon for the pressure to be low initially. And then it settled and seemed to stabilize. So by February 2018 still, she seemed to be quite good. So that's almost 3 years. That's her visual field.
Sorry, Joe, but with all the permutations, combinations, and everything else, trabeculectomy never made it closer to the top of the list than right at the very bottom after going through all of that?
Well, I think it's quite appropriate the way she went through her journey. I mean, she turned up for appointments, and I think, just looking at the time frame, because you do have to give the drops enough time to work. And, she wasn't showing any signs of progressive change even though she had an optic neuropathy. And surgery, is not to be considered lightly, because surgery is not this magical, quick fix. There are fish hooks with surgery. So, I think that is one of those things that you do want to be satisfied that you've gone through exhaustive medical management before you embark on surgery, because it's not without its own issues. But it's a fair question. Just looking back, you kind of sometimes wonder when you see in hindsight how patients have kind of we've sat on it. It looks like we've sat on it for a while, but some of the conversations that you have with your patients, they're not that keen on having surgery.
Well, the surgery setting looked like a good outcome, but I'm sure you've got patients where the outcome wasn't as good as that one.
But that was only 2018.
Okay.
But wait, there's more. So, and bear in mind, she's still young. She's only like 45, 48. She's still got at least 3 to 4 decades ahead of her potentially. Okay, so certainly, but I take your point. She's definitely got signs of an optic neuropathy, and if I saw somebody like that and it was stable, whilst I recognise that her pressure might not be ideally controlled, we do tend to want to have evidence of the deterioration before you take that relatively drastic step of proceeding towards surgery. Okay, so and of course this is the Zeiss, and that is the Topcon. Anyway, it's not apples with apples in terms of numbers, but you can certainly see that there's progressive thinning potentially. That one's 2018 and this one's 2014, so over a 4-year period. So continuing on with her journey, she's now 48. This is 2018, and just out of the blue, her pressure on the left eye goes up again. And her eye was quiet. But fortunately for her, she had some pain. So there was a symptom that brought her to, that drove her to seek a check. And so she was started on treatment again. And, this is where the patient journey is also dotted by patients' own ideas about treatment. And maybe she'd had a miserable time with some of the other eye drops, and so she got it in her head that the high sight causes side effects, and so she stopped it on her own. And you can also see that I'm not really sure the rationale of her being on Dortem. I call this desperation, where you're on Dortem and then somebody adds dorzolamide, because Dortem is dorzolamide plus timolol. So, and maybe, we just had a new registrar who didn't really know, or it's, heading towards Christmas, and, that Christmas wasn't a very happy one for her because the pressure went up even further. So we managed to convince her to start back on high sight. But, certainly we're documenting now that she's intolerant of timolol, bromonidine, and dorzolamide, and definitely running low on options. So I don't know if some of you are familiar with Betoptic. It's not one that we use very often. It's a selective beta blocker. And the idea of it is that supposedly it exacerbates asthma to a lesser degree. So when you're backed up in a corner, sometimes that's what you try. So bearing in mind that potentially we are noticing some progression in her disc, because it was 0.7 when she first came to us, and now it's maybe 0.8. And interestingly, she seemed to tolerate the Betoptic quite well. But again, trying a whole bunch of different drops, the high sight was stopped. I'm not really sure why. Maybe they thought it wasn't effective, but I just wouldn't have thought that time frame is long enough. If I'm trying to get somebody on high sight, I would have them on it for at least 6 weeks before I can determine whether I've actually got a response or not. And in the meantime, if I'm trying to, because I don't know if any of you have ever tried to take medication diligently. Well, if you're anything like me, 4 times a day dosing is completely hopeless. I would be completely non-compliant. 3 times a day, already pushing it. Twice a day, well, maybe I'll remember. But once a day is manageable because, I've got a little routine in the morning where, I'll be more reliable. And I think this is something to be mindful of. These patients, it's a chronic condition. They have to remember to put drops in every single day. Twice a day, 3 times a day. They've got life, they're suddenly out shopping or they're visiting friends and, I forgot to bring my drops with me. That's just normal. So usually what I try to do is I try to give them, so if say somebody came with a pressure of 40 and I don't really feel comfortable with them, with putting high sight, well, with having them on high sight from the outset on its own, because I'd like to see the pressure drop down, I might say to them, if they don't have any contraindications to timolol, I might say, well, take the high sight as well as the timolol, but 48 hours before you come and see me, stop the timolol so I can see what your pressure's doing just on the high side alone. So those are some of the things that that I'd like to do. But so I'm not really sure why her high sight was stopped. Maybe she was still believing that it was irritating her, and it could well have been because for some people the prostaglandin analogs are quite irritating. And if you can't get them, my experience, the first 6 weeks are the worst, and if they can kind of get over that hump with some lubricants, and it is the reason why prostaglandin analogs have typically been prescribed at night time, so that most of the irritation happens while people are fast asleep. But the best time of the day to take the prostaglandin analog is when they're reliably going to remember. So it doesn't matter if they use it in the morning. So you can see her journey. Pressure kind of went up, and we started adding things, and then alpha-GAN-P, just because she was starting to. We're now backed in a corner, and we're really struggling to find something to control her pressure. She's already had a trabeculectomy, and it's starting to look like it's not working anymore. And, it's less than desirable to have to subject somebody to a second operation. And she had felt that bromonidine had made her psychologically very unsettled. So she was really reluctant to go on alpha-GAN-P. And alpha-GAN-P, I don't know if you'll know, but that's the preservative-free version of it, and I'm not even sure that it's fully funded in New Zealand. Anyway, and then she turns up in February to the emergency department with her vision being cloudy. She's got more cells, and so she was treated. The vision did improve. I don't have the ED notes, so I don't know what her vision was. But then by March, pressure's not ideal, and she feels like the Predfort makes her eyes swollen. It's kind of hard to know because it's supposed to do the opposite. It's supposed to help the inflammation. And anyway, she was told to continue on the betoptic and the bimatoprost. So by May, pressure's really not great, and she can't tolerate the betoptic anymore. So we got her on bimatoprost and azopt, but you can see which way we're heading. We're heading in the direction of more surgery. And when you're struggling, you kind of, it is really great that we have colleagues that we can lean on. So she got referred to the uveitis clinic. I didn't see her. I was just, all this is just from the notes. She got referred to the uveitis clinic, and it's kind of like help, please. And that's her field. So 2018 to 2019, you can see that there's some progression. So by July, she woke up with a headache and she was vomiting, and pressure was found to be 30, and there was a thought that maybe it was also the steroids that were making it worse. And she had some inflammation, so to try and treat the inflammation, we gave Voltaren instead, and iopidine, which there's no mention of how she tolerated the iopidine, because it's really same family as brimonidine, and I don't know. Anyway, so by end of July, we figured out that she had been on maximum medical treatment, whatever she could tolerate. Pressure control was still not adequate, and it was felt that her bleb needed some revising, and it was done under general anaesthetic. So as is not uncommon, the pressure's now swung the other way. It's down to 3, and a month later it's only 6, a month later it's probably about 4, but really what's the difference between 3, 4, 5 and 6? It's probably all just errors of measurement, because it's quite tricky to really reliably measure the pressure when it's that low. She didn't have another great Christmas. Pressure's down to 3, but at least the bleb looked fine, and it wasn't leaking, it was behaving, perhaps not unexpectedly. And the first time I met her was in April, and I'm kind of thinking, this is now like 7 months and your pressure's this low. But the thing is that she's coping well with it, because her fundus looks fine. Does anyone know what happens to a fundus, or what it looks like when it's suffering from low pressure? Anybody seen? So you have these things called choroidals, which basically just looks like the fundus is sagging, and you can get these kissing choroidals, which just means that one side of the globe to the other is just completely sagged in, and one side's touching the other. So it's been described as kissing choroidals. And then you know that your patient is, the low pressure is really impacting. But fortunately for her fundus looked fine, and her vision's still retained, and her guided progression analysis is stable. And so you can see how this is April 2020, and that one is 2018, I think. Or 2019, so I should read my own heading. And you can see how, that's not surprising, that diffuse thinning of her optic nerve on the left side. And sorry, I haven't been able to get the guided progression analysis up. So Mr. Fuchs was Austrian, and he described this in 1906. And, depending on the study that you look at, it can be somewhere between 1 to 20% of the reasons why you see anterior uveitis. And previously has been known as heterochromic iridocyclitis, but I think the reason why people have moved to Fuchs Uveitis Syndrome is that there's a spectrum of signs that you can see. Some people don't have the heterochromia. And it is a chronic condition, typically unilateral, but it can really be bilateral, unlike the Posner Schlossman. And commonly, they have no symptoms. One of the key features is that the vitreous can have some inflammation. So that can be quite helpful from a diagnostic point of view. So the articles say. And then they get cataract and secondary glaucoma. So, yeah, and then the inflammation is mild. You only get a little bit of mild flare, maybe minimal cells. The KP are described as stellate, so they're small. And the iris atrophy is also the reason why you get the heterochromia, but you don't always have that sign. And the iris atrophy is also the reason why your iris vessels become prominent, and you might end up seeing angle vessels. It's interesting to see that some of the journals actually describe it as rubeosis, but I'm not really sure that it's rubeosis as we know it, as in a neovascular, ischemic kind of rubeosis. But anyway, that's the term that they use. If your pressure is elevated, it could be due to a number of reasons, and those are some of the reasons listed there. So you might have PAS in the angle, your trabecular meshwork could be scarred, and so on. And sometimes it is steroid induced. It is interesting that they can have recurrent spontaneous hyphema, and I'll come back to that in a moment. But the interesting thing about the KP is that they are described as being spread all over the cornea rather than the inferior part, where I think it's got to do with the way the aqueous swirls through the anterior chamber and the deposits on the endothelium. So maybe if you see stellate KP distributed diffusely across the cornea, that might ring a bell for you. And some rare things which you wouldn't really see, and we certainly wouldn't expect you to pick up, but it was just interesting. Now that we can do OCT and OCTA, we can see the choroid as well, which is a new thing. So there's some choroidal thinning. Really, it's bilateral, and you'd really have to get a 3-mirror or do indentation examination of your fundus to see the snow banking on the pars plana. Just a little bit on the iris heterochromia and some of the other features on the iris. So you can get the heterochromia either because your iris stroma undergoes atrophy, or you lose some of the pigment in your iris stroma, or otherwise the pigment epithelium, which is really the posterior layer, that loses its pigment, and then you get the transillumination. And usually the transillumination happens more first on your temporal iris before your nasal iris is affected. So do you all know how to look for transillumination? It's one of those things you have to look for, and you actually really have to make sure that your room lights are dark, because if it's subtle, you can miss it. So iris nodules, and I have not seen these. Maybe I've missed them and not identified them, and maybe they're just not that common. But apparently on the pupil margin, they're called Kuppi nodules, and on the iris surface, they're Busaka nodules. And those terminologies are also used in other forms of uveitis, but these are the sorts of things that we grill the registrars for if they're going for the gold medal, I reckon. And the lighter color iris is, if you have a lighter color iris, you can get inverse heterochromia, because with the iris undergoing atrophy and exposing the iris pigment epithelium, your iris will go darker. So you can see, Jenny, do you mind just dimming the lights for us, please, if you don't mind? So here's a patient that I saw. The top one is from this morning, and she has very, very, very subtle heterochromia. And I only know it because I know that her right eye is affected, and when I look for the transillumination, you can see some transillumination on the inferior iris. And it's just one of the reasons I took the photograph is partly because if you catch her looking at a certain angle, you can see it. But it's one of those things, I know she's got it, and I was looking for it, and I was trying to find a photograph for tonight's talk. So, but yeah, if you don't look for it, it's easy to miss. And here, this is a picture from the internet, and I'm not entirely sure which side is affected. Shamelessly, I've taken this off the internet because, obviously there are other causes for heterochromia, and the one that I would see rarely, because it happens rarely, is Horner syndrome, especially if it's congenital. Certainly glaucoma drops, pigment dispersion syndrome. So yeah, there's a whole bunch of, and then there's a few things in the fine print, and I was going, oh yeah, I'm not sure that I remember what those things are, but anyway, okay. So the clinical findings can be quite diverse, and that can sometimes make it difficult to make a diagnosis. And they can be asymptomatic for years, like this lady was. And, the features are just discovered incidentally. And the examination is just all the usual things. But I think it's worth paying attention to the vitreous, because sometimes it's overlooked. And I mean, we wouldn't expect you to describe this, but it can be associated with optic disc hyperfluorescence. Obviously, you have to do a fluorescein angiogram, as with the peripheral retinal vascular leaking. And on OCT, as I mentioned, we can now look at the choroid. The challenge with this condition is that it's not a condition that responds to steroids. And as soon as any of us see cells in an anterior chamber, it's almost like a knee-jerk response. You pull up the bread fort. And sometimes when you're faced with a situation, you actually have no choice when you don't have a lot of other signs. But, typically, uveitis, especially if it's an acute iritis, they should have quite a lot of symptoms. They should have a lot more cells, a lot more flare. They might even have posterior synechiae. And they'd have more obvious signs of acute iritis than just the subtle, incidental detection of low-grade cells, not a lot of symptoms. So, I guess it's just one of those situations where you have to think and put all the signs together. What might look like Fuchs Uveitis Syndrome? Well, Posner Schlossman, but that responds to steroids, and that those attacks are more. They have an attack and then it settles down. Any other form of chronic uveitis, because certainly you can have people with chronic uveitis that have no symptoms, and other cause of anterior uveitis. But hopefully there'll be other clues. So, for example, if you have shingles or with zoster or herpes simplex, you might have skin lesions, you might have reduced corneal sensation. So we're always putting clues together. I think that's one of the fun things about our profession, is that all the signs are there. We just have to draw them out. And there's lots of theories as to why, but I think the thing that people probably conclude is that it's the low-grade immunoreactivity in the anterior chamber against a virus. Rubella has been thought to be quite a culprit, HSV, toxo, and CMV. Cataract surgery is interesting because fortunately now we live in a day and age where we do phaco. But in days gone by when we used to do eckies, I don't know if some of you younger ones know what an eckie is, but so forgive me if I'm telling you how to suck eggs, but an eckie essentially involved a cut of the cornea 180 degrees across, and we didn't have the phaco technology to be able to break up the cataract on the inside and work through a 2.4 millimeter size wound, and we also didn't have foldable lenses in those days. So what would happen is that you'd open up 180 degrees of the cornea and remove the entire cataract all in one piece. And you can just imagine how much instability there is in your anterior chamber pressure. And so they had a lot of issues with bleeding and so and then back in those days they were going, wow, we're not really sure that we should be doing cataract surgery on these patients. But certainly with phaco, all of those lists of complications, they could happen whether you have Fuchs or not. In my limited experience of doing cataract surgery on Fuchs patients, they've done well so far. So I think that phaco is a much safer procedure for them. Glaucoma is the leading reason why they lose their vision, and that's where I guess we all come in and play our role. It's common. Depending on the study that you look at. I mean, it's quite a range, so I guess it depends on what snapshot you're getting of your patients. And the trouble is that they don't all respond well to surgery either. So my bet is that this lady that I've been presenting to you, she's going to end up needing more surgery at some point in time in her life. And the next operation will either be for somebody very brave to do a repeat trabeculectomy, but I suspect that she'll need a valve or a Multino drain or something like that. And there are some studies that say that patients do better, but I think, it's one of those things that, again, we don't have extensive studies to show. Is it trabs that do better? Is it drainage devices that do better? And I think it's quite reasonable to start with the trab and then move on to a drainage device. So I think these are my last 2 slides. You've done really well to all stay awake. It's time. So remember that Posner Schlossman affects younger people, so even younger, 30 to 60. It tends to be a unilateral recurrent condition where patients may not have as many symptoms as you might expect, but they might present to you with reduced vision, discomfort, and a mild red eye. And their pressures can be significantly high, not a lot of inflammation, and they'll have crises which could be variable in their duration and be completely normal in between. And you might only catch them when everything's quiet, but you notice that they've got the disc asymmetry. Unfortunately, they do respond to treatment, but long term, they don't tend to do well because most of their episodes are asymptomatic and they don't even know it's happening, so they don't present. The take home on Fuchs is that it's a chronic condition, often asymptomatic as well, typically unilateral, but you can get bilateral cases here. The inflammation again is mild, and maybe those stellate KP that's distributed diffusely will be your telltale sign with the heterochromia. And you might see prominent iris and angle vessels because of the changes on the iris. And again, cataract and secondary glaucoma are the issues. And if you see somebody with posterior synechiae, we're not likely to make the diagnosis of Fuchs because you usually have quite a lot of inflammation when you've got posterior synechiae, and you don't have cystoid macular edema either. So that's it. Well done for staying awake after a long day. Anybody got any questions?
How would you get your lady's pressure up if you needed to?
Well, actually, my thoughts are that I don't want to. And in fact, she's fortunately doing well. If she had choroidals and her vision was dropping because the pressure was low, then we'd be forced to do something. How? I refer her to John Rawstrom. They're challenging patients to manage. And quite honestly, I don't really know how. They'd be fiddling with, they might put a stitch in and try and reduce the filtration, but it's incredibly challenging because the problem is that you're really on a tightrope. Either way, you're either going to swing low or you're going to swing high. So they're thankfully not patients that I have to manage. And thankfully not patients that we have to, it's not a complication that we have to deal with too often, which maybe is also one of the reasons why we struggle to manage it. So as long as she's not having any issues, I think low pressure for her is the lesser of two evils, because I suspect at some point in time in her life her pressure is going to creep up, and then we'll have to deal with it. So for now, she's understandably a little unnerved by that low pressure, and I've just tried to reassure her as best as I can that low is better than high in this case.
You tried palpating it? How would it feel if you just went on a 3 millimeter eye? You go pum, pum, pum.
Yeah. Probably would be very soft.
Yeah.
I mean, and it's true because I really struggled to get a reliable Goldman tonometry reading. And sometimes I just couldn't get it. So I think it's that soft.
With the Fuchs Uveitis Syndrome, does it always lead to secondary glaucoma, or could the pressure be normal and the disc be normal?
I suspect that it's quite a large proportion of, so I can't remember, I mean it depends on which study you read as well, but I think it's a reasonable proportion, probably at least 40 to 60%, and I suspect that if you study these patients for enough years that you'd find that they're more at risk of developing glaucoma, that numbers will go higher.
So like, for example, if the pressure is normal in those patients and the disc look normal as well at the time, would you do anything about that?
No, I would probably just monitor them. So my lady today, she's just recovered from cataract surgery, and we're just going to monitor her. But I guess it's one of the things I think would be useful is to say to the patient, look, you've got this condition. I expect that at some point in time in your life, you've got a high risk of your pressure rising and causing an impact. Because then that also helps them to understand that they need to turn up for a regular check. You know, they don't just get a letter from us or the optometrist to say, you know, come in for your check, and they just go, oh, I don't need it, I don't have any symptoms. So, you know, just part of our role is to educate our patients so that they understand what they might be at risk of developing and why we're doing what we're doing. Yeah.
I also have another question. Sometimes I see elderly patients and their pressures for both eyes are quite low, like for example 5 or 6, and they're completely asymptomatic.
Yeah.
Do we need to do anything about that?
And again, yeah, it is quite interesting. I notice that sometimes. And no, if it's not affecting them, because the trouble is that actually it's quite interesting to see some of those patients, and they haven't even had surgery. You know, they're just low. So in those cases, I wouldn't. I haven't seen anybody, to my mind, that is having any vision issues related to low pressure. Right. So again, I think in that circumstance, it's low is better than high, and as long as they're not having any. You'll see the entire choroid just kind of sag in, and it's unmissable. You know, even if you see it for the first time, you'll kind of go, that's what it is. The whole eye is just kind of sagged in, and yeah. But if they haven't had surgery, that's not likely to happen. Yeah.
So I just have one last question that's not related. I've had a few patients who I referred for cataract surgery just before COVID who didn't meet the threshold
who
at
did,
the time. But because of the pandemic, they've all been rejected. So what happened? What should I do at the moment?
Sit tight and hang on to their names. At the moment, and you'll find this, it's all I can say is please bear with us, because we're trying to deal with it, and higher level DHB is trying to manage it as well. And the solution is we need more funding, more clinics, more staff, and that's not going to happen immediately. So what we're trying to do at the moment is the hospital has given us authority to only accept patients that are less than 28 days. And what we're trying to do is the patients that we would normally accept as a 3-month, like your glaucomas or your cataracts, we are keeping track of them. But I think it's at the moment, I'd have to say that the system is not foolproof. So what I would say is if you could keep track of them, if you could say to the patients, look, if you still haven't heard from the eye clinic in 3 to 6 months, come back and we'll write to them again, because we're in a period where we are actually struggling to keep, like I said, before COVID we weren't good. Now that it's post-COVID, it's even worse. And the cavalry is not coming. And at the moment we are struggling. So anybody that needs to be seen urgently is still getting their appointment, but the ones that we're struggling with is the routine, and even we're recognizing that the glaucomas that, you know, like they shouldn't really wait that long. So if you see your glaucoma patients and you see that they've been rejected, please schedule another check yourself, 6 months or whatever, and keep monitoring them, because basically anybody that's you notice to be deteriorating, write to us again and let us know, and you know we're just doing our best to cope with the load at the moment.
Do you find the ERME system, the for your information and written advice only options, quite useful to get information through that way from, say, patients who are between appointments for
Yep.
things?
So that comes to us. Yeah, it's a reliable way. Yeah. Do you find that works well?
Yeah.
Yeah. I think the ERMS method is better, especially if you're able to upload your things. Are you able to attach?
You can do images.
Yeah. Yeah. So if you can attach them in colour, then it saves us from getting a fax in black and white, going, okay, we can't really make a judgment on this information because the information's not coming up, and that to and fro could finally get back to us 2 to 4 weeks later. So that'll help to avoid delays. So yeah, it works well. We use it a lot.
If we send photos through via ERMS now, does it come through in colour, or do we have to email it through as well? Because I know previously I had to email photos through as well as put them through on ERMS.
I don't know,
I think I
actually,
can do both anyway.
to be honest.
Yeah.
I don't know, because I just get it.
Okay.
And I suspect there's a few elves in the department that
Yeah.
recognise it's in black and white, and then they contact you and go, could you please send it in
Yeah.
colour?
It's happened a few times,
I certainly know, because we're still getting some hard copy referrals, and those ones sometimes we definitely have to send back.
Mhm.
Yeah. So, yeah, sorry, I can't
That's okay,
tell
I'll
you.
just keep doing both,
Yeah.
that's fine.
Yeah.
Would Sudhanai be taking private referrals through elves?
I think we are working on. Our little elves have gone. Justin and Chrissy would have been able to answer. I don't know, Steve, to be quite honest. Not yet. I know we've been discussing it. We're trying to make it more kind of user friendly and accessible. Yeah, but sorry, I'm not the right person that can comment. If you like, I can ask Chrissy or Justin to get back to you tomorrow. If you, yeah.
In time.
Okay. All right. I mean, look, I think once we are fully electronic, I think we're doing a lot by email, and some of the ocular systems are working quite well. But, once we have a system up and running, I'm sure that we'll be notifying everybody. Yeah. But again, I have to confess, I receive it and then I work on that end, not on this end of it. Yeah. Does anybody else have any other questions? Right. Okay, well done for sitting through all of that. Feel free to have another drink, have some nibbles, because we're allowed to. We can socialise a little bit if you like. So feel free to. Yeah, thank you very much for coming.